We'll move to a different subject, pediatric emergencies. We have Dr. Shahid Rashid. Dr. Shahid Rashid is a pioneer specialist pediatric surgeon in the region with over 2 decades of experience. Let's welcome Dr. Rashid. Thank you.
So you are right on that. It's a different taste. Surgeons always are like quick to move, quick decisions. Here I have lots of submissions to make. Exclusive of trauma, I'll be talking of common pediatric emergency where we are being shadowed by all of you. So the whole idea came up when Dr. Dina told that it will be a multidisciplinary, different subjects will be handled. So I felt that I should push myself in. And thank you very much, Dr. Dina, to accommodate a surgeon. So the whole idea is the same. You know, the center point of all of our activity is to some or the other benefit the patient. It can be physical, it can be psychological, economical, all of these stuff which we have discussed in today's talks before me. So time saved, it can only be achieved by the teamwork. There has always been a reference of having multidisciplinary approaches in many of the conditions which we heard in the morning. So I'll just try to create a balance or create a schematic idea according to our institution. It will differ with anybody, you know, who's coming from different organization according to the facilities available. You have to draw your own algorithms, and the player in my mind always is pediatricians to begin with, from which we get most of our referrals. Emergency physicians, obviously, general practitioners, pediatric surgeons. We have a cross referrals as well according to our capacity, our facilities, and I have put a red mark there. I think there are no radiologists here. I wanted to highlight their role in our practice now and how they can contribute. So I think all of us, all the pediatricians, you know, the child is not at half adult. Age and weight matters, all our dosages and, you know, different parameters. Anatomy, this is what has intrigued me since I have started pediatric surgery, that pediatric surgery as per se is not one dose, one title. It varies from the, you know, the classification antenatal to postnatal, or the infancy in the childhood, and then the puberty, which is slowly barging into our age limits. So gold standard remains the same: history, physical examination, investigation, and the treatment in the same order. This is as we have been taught all our lives in our medical schools. We are teaching it to our junior colleagues, our students. It holds true till, I would say, that till this medical science is practiced. So it is a time saver as well. You don't miss a thing, and at the same time you don't do anything unnecessary. So this is how the order works. So I've picked up few common conditions which probably both parties as pediatricians and surgeons we see commonly, and this is where our there's a long list, but I think these are the common ones which I would refer to, and I will try to go as fast as possible. All right, so we start with the acute red scrotum. This is the true emergency. Most likely this will be handled by the urgent care doctors, but sometimes, you know, pediatricians also get. So time is an essence. Why? I'll explain it to you later. It can happen. The condition I'm talking about is torsion of the testes. Any acute red scrotum will be taken as torsion until proven otherwise. This I'll highlight in the next slide as well. So the age, it can be antenatal, you can't do much about that. Postnatally, yes, possible. Early childhood, especially with the retractile testes, and I will allude to this in my next my next topic as well. So the history goes like it's a sudden onset, it's continuous. There can be history of trauma as well. The red scrotum is the key here. The testes, which is affected, is usually higher to the other side. So whenever we have two organs, we always compare them, and that will give you the clue itself. It's tender, very tender. Children are very honest. So if it is painful, they are going to tell you. So you cannot touch this, and obviously he's in discomfort, and any movement will increase the pain. Investigation, as I mentioned, it's a luxury. It is only the time between the primary physician contacts the surgeon, the gap or the window, you can use it for investigation, and the best now is Doppler ultrasound. I have just, for the reference, I have sent the other possibilities. Previously, we used to have, for the place I worked, there was an isotope facility was there, meaning that you could do these tests. So they might ask for a radioisotope, but again, it's a cumbersome, it's a time-taking process. So if the investigations are not available, you are in doubt, I am in doubt, I'll open, I will explore. And it is legally, I have got more cover in exploring with negative results than leaving it and ending up in trouble. So as I mentioned, the other differential diagnosis is there, but the first one remains valid till it is proven otherwise. So the history will be different in epididymolysis. I don't want to go into longer details because of the time constraint, but there will be a history of fever, longer duration. Torsion appendix can mimic torsion of the testes, and if you are in doubt, open it up. Usually you can pick it up on ultrasound. It is lesser, subjectively speaking, lesser painful than the acute torsion of the testes. But again, on the cost of repetition, torsion testes, if it is there that you are doubtful, open, explore. And the scrotal edema, it's usually painless, but ugly looking red scrotum, that might cause you to worry. So urgent referral to the pediatric surgeon. As I said, Doppler ultrasound is the best for me. That will reassure me. If the Doppler flow is good, I probably can sit on it. Surgical exploration is the way. If time is taken too much, this is what you end up with. So we don't want that. I come back to the second topic, which is inguinal scrotal swelling. Again, it's a very important in the sense that we see it quite often, and usually it is the mother or the pediatrician who's examining for like coming for vaccinations and other stuff. There can be no symptoms, there can be pain, vomiting, constipation. So these are the things which might suggest that. But once we are talking of the importance itself, from the surgical point of view, the chances or the reason we take it as you can say as an emergency thing is the possibility of obstruction and strangulation to it. So very quick, as I said, the history will be coming that the mother sees swelling while examining or changing the pampers, or doctor sees the swelling on crying. Quick physical examination, if you can reach above the swelling, it's not hernia. It's a hydrocele or whatever, or it's a scrotal swelling. So if you cannot reach above the inguinal, the swelling, it is most likely inguinal hernia, and then the next thing will be to check reducibility, and usually they are reducible. If they are not reducible and tender, you are suspecting obstructed, moving on to strangulation. So a quick Doppler ultrasound will help us, but as again, if you are in doubt, the facility is not available, we'll explore. So this is a picture which saves me from 1,000 words. So here you can see, all right, so I just wanted to, the lower picture had hydrocele and inguinal hernia in the same patient, so I could have pointed out for the filling on the left side, which was the inguinal hernia. So how would you go about this presentation? If you can reach above the swelling, it is hydrocele, painless, no complication, and you can wait for 2 years. Usually we don't operate for 2 years. For myself, if the swelling is getting smaller, meaning the hydrocele is getting smaller, I'll give even more time to the child. If I cannot reach above, it's inguinal hernia. If it is reducible, I will plan for the next elective list, and I'll do the surgery. If it is irreducible, manual reduction, successful, I will again wait because of the difficulty in operating in emergency, because this hernial sac is very edematous, and as my tutor, he explained that it is just separating two wet tissues from each other with the edema of the sac. So I would not like to do it. A very critical structure adjacent to this inguinal sac, like testicular vessels, vas deferens. So I will delay it for the next elective list. If it is unsuccessful, we don't have a choice, we go for emergency surgeries. All right, so just to lighten up, give me a chance to breathe. Which one is to be done first? The right or the left ones?
5 minutes.
5 minutes for me? So I have lost. So left is important because of the narrow sac in the infant. So you can see the age from the picture itself. The female can have a torted ovary in it, and the right one can have undescended testes with a torsion. Next topic is bleeding per rectum. I have chosen out of the differential diagnosis interception, which is very common, and it spoils most of our. I don't know why they come in the middle of the night or in the late evenings. So they do come, and previously it was the only thing we would hear from the urgent care: excessive crying. And usually the other symptoms are colicky pain, it's sudden onset, recurrent, vomiting can be there if it is for long duration. You can feel a mass in the right quadrant of the body, or sometimes on the left as well. Red currant jelly, we don't wait for this, but if it is there, then possibly we are dealing with intussusception. So very quickly, the proximal bowel invaginates into the distal one, and we treat this as intussusception. So what happens next? The physical finding I've mentioned about. The next best thing which has happened is radiology. Is now whenever we get a call that it is excessive crying, possibly intussusception, please do ultrasound. If ultrasound shows intussusception, the game is on. Time saver is that before even the surgeon is called, you call the radiologist as well, because he has already reported that it is intussusception. The first thing we try is hydrostatic reduction under ultrasound guidance. So my presence is only for reassurance and praying that he is successful and we don't have to operate. So you can just quickly look into the algorithm I have created here. So intussusception positive, hydrostatic reduction, unsuccessful, surgical exploration. If we are successful, we are good. So these are the possible ways of dealing with this reduction method, as I mentioned. Now I just have a video, I hope it works. All right, so just quickly, it is basically to show you how the intussusception happens. Usually there is the leading point. Commonly known etiology are the swollen or enlarged pyre patches in the terminal ileum, but in this case, it's a unique case. It's a mecal which has pushed on itself and then pushed the small bowel into the colon. So I hope it moves faster, otherwise I will not lose. So here you can see this is the mecals, which has invaginated on itself first and became the leading point, going through the distal ileum into the colon. So coming to the next topic, which is pyloric stenosis, non-bilious vomiting following feeding, which is projectile. Usually it's neonate to the infancy period. Child is hungry after the vomiting spell and then wants to drink again, and this cycle keeps on going on. And because of the outlet obstruction, there is dehydration. You could see loss of weight if it is prolonged. Scaphoid abdomen means there is no gas distally in the small bowel. You can see visible peristalsis, and I might be able to, yes. So, sorry. If it works, so you spend some time sitting at the level of from the lateral side of the child. After feeding the baby, you try to look for the peristalsis, which is from left to right because of the dilatation of the stomach, and the peristalsis in stomach is from left to right. So I'm going to skip this.
2 minutes left.
Okay, so you can find investigation, just reassuring you that your diagnosis is correct, is hypochloremic, hypokalemic metabolic acidosis. Just keep it in mind because, again, as I said, diagnostic, radiology, we usually now depend on ultrasound, which gives us the enlargement of the pyloric canal and thickness of the pyloric muscles. X-rays, they might give you a single bubble. We don't do barium anymore, but very rarely done. And the game plan is here. If you can just quickly go through it. GP, pediatrician, EP, radiologist, everybody is involved. Abdominal ultrasound shows canal is, like this is the dimensions which are suggestive. Time saver is that don't have to go jump onto the pediatric surgeon. It needs surgery, but it needs to be stabilized. So we correct the electrolyte imbalances, and then pediatric surgery comes into play. And this is pyloromyotomy. This is horror movies over. Let's go to the most common things which we face. And this is pain right iliac fossa. No age is exempt. But if you see it in the extremes of the age, usually you have complications. They are delayed for reasons which we know that in infancy the omentum is not fully matured. So usually the acute inflamed appendix is not covered or protected by the omentum, and the peritonitis happens. It spreads all over. It becomes generalized. Same is true about the older people. They have low resistance, so in the extremes, as I said, it is usually with higher complications. So clinical, for old people like us, our hands are trained to pick up appendix. So I always request when anybody refers a case, is he tender, is there guarding in the right iliac fossa, I am in. Otherwise, we can just, add take the added help by doing investigations. All right, so I take a minute and then we go on. So very rarely we can ask for a CT abdomen, usually for the female patients where the pathologies are more. In fact, acute appendicitis can be mimicked by any in the previous surgical books. It can involve, as they say, from brain to the pelvis. Anything can give rise to pain right iliac fossa. So CT abdomen with contrast is conclusive, very high sensitivity. So this is so I'll just skip through all this, and how we do the appendicectomy. You can look at so we go for the mesoappendix, put in the clip on the base. It's a standard, but now we have, this is the favor, so you can say it's a standardized thing to offer because of the scar, and in fact you can manage a lot of complicated appendicitis better by laparoscope than doing an open surgery, which the chances of having abscesses or wound infections are higher. All right, so I think I gave you a glimpse. This is a quick algorithm for that. So tenderness right iliac fossa, call the surgical help. If tenderness guarding is not there, there is no leukocytosis, no neutrophilia, most likely it is not appendix. So medical people should handle this, and again, it's the cost of repetition. This is how we can save time so use all available specialties to the optimum by developing coordination to save time. And as we are saving time, we are saving money as well, saving psychological pressure on the patients as well. We can have our own custom built algorithms according to the expertise available. Like for example, for us, for intussusception, when I spoke with our radiologists, they were more comfortable with doing contrast enemas rather than hydrostatic ultrasound with saline, whereas the barium thing will have exposure to the radiation, and ultrasound guided saline reductions have lesser exposure to the radiation. So I requested them that we can do it together to begin with, just to create a better safe environment for the patient. I think I'll stop here.